Thanks for joining. My name is Steve Rotman. I'm the Chief Executive Officer here at WISHIN. Also joining me from WISHIN, Greg Staddard, our Director of Operations, Matt Jago, Director of Population Health Analytics, Tom Roll, our designated marketing guy, also customer outreach. We have Laura Witter, project director in all things HIE technology. And I know I'm missing, Carol as well. Carol is our outreach engagement specialist. So I may have missed others like Lisa, but I'm going to get moving on to the other housekeeping items. Related to introducing yourself, please use the chat feature. That'll be the best way to engage with you today and understand who's on the call. We will also use the chat feature to address any questions that might arise during the conversation. The purpose of today's call is not to rehash the changes and dispute or defend any of the changes. The purpose of this education session is to educate you all on the changes that have gone through the appropriate review, discussion, and approval channels that allow you as a participant of the network to make an informed decision. As is called out, specifically provider organizations have the ability to opt out, and we want to make sure opt out of some of the data that is being exchanged, primarily with health plans, which we don't encourage, but we do want to educate and inform you on your rights as a participant, but the benefits of exchanging this data through WISHIN. Again, please use the chat. My team will be following that and addressing any questions. I will not, because then that'll just be a distraction for regarding what I'm trying to share with you. So with that, let's get going. The Participant Advisory Board is a group of representative organizations of the entire customer and participant base. These individuals represent payers, providers, the state of Wisconsin, and other organizations. What is called out within the participation agreement is for any material changes to come into effect or even be recognized, it begins with the Participant Advisory Board, or PAB. So that the PAB was brought together because of many changes that our participants wanted WISHIN to explore and to provide better value and greater interoperability across the state of Wisconsin. We had, again, brought this group together starting in February of this year to discuss a number of changes. Those changes went through a review process with very good and sturdy conversation about the efficacy, the value, and the alignment with HIPAA, privacy and security, state regulation, federal regulation, state law, etc. There was also a process through February, March until the time we voted in July, where we had one-on-one conversations with a number of participant organizations, security teams, compliance teams, legal, etc., to allow these changes to go through that process and vet the utility of these changes, and was it in accordance with federal law, state law, etc. That group ultimately landed on the changes that we will review and has been provided to you either by mail and snail mail. July 11th of this year, where we looked at each individual change and voted unanimously. All participant advisory board members voted yes to these changes. That the next step then was for us to bring these changes to our larger board. And before we did that, we went through a process to inform our executive committee. All of that took place, and September 23rd of this year, the board voted to adopt all changes that again, that we'll be walking through here. These changes are effective January 19th of next year. So in just a few months, the notification period that exists is once the board approves those changes, we send out a communication, which has already been done, as I shared through snail mail and email. Through that process, we are conducting 2 sessions, this being the first of the 2. And then 90 days from that notice, or at the end of that 90-day notice period, those changes are effective. And that would lead us to January 19th. So let's get going then through all of these changes. Again, please use the chat. The team will be monitoring that chat to address any questions. We will go through all of the changes and then field any questions at the end, just to make sure we get through all of these changes in the allotted time. Summary of all of the data sharing participation agreement changes. We are aligning public health activities with federal regulation, and really that's 45 CFR 164.512B for those looking at federal regulations this morning. We are including explicitly ADRCs, WIC agencies, and community information systems, or CIS, agencies or organizations, population health efforts that exist across the state. We are authorizing explicitly, again, the exchange of social determinants or health-related social need data. That has not existed definitively, and that's what we're calling out here. We are committing payers to strengthen the provider communication related to care coordination activities. The feedback there that we'll talk through is where there's coordination, making sure that where WISHIN is used, that in kind, there's a communication from the health plan to the provider, harmonizing existing payer access use cases. That's specifically talking about use case 7 that we'll walk through. Addition to use case number 8, risk adjustment, risk management, to the previous 4, now with risk adjustment 5 permitted uses under use case 8, and the addition of a net new use case for population health data assets, enhanced analytics that we will walk through. Okay, so the change to public health activities, as I mentioned, this is aligning the data sharing participation agreement with 45 CFR 164.512B, where it states the use for public health agencies exists for use and disclosures for public health activities. The goal here is to remove any ambiguity and also opening the ability for public health agencies to access individuals within their jurisdiction, within their county, at a state level for appropriate and approved purposes related to public health activities generally, not limited only to reporting purposes. The second change is related 2.4 and all of section 2 of the data sharing participation agreement relates to the permitted users of the system. So we are calling out specific organizations like aging disability resource centers. And if I said that incorrectly, I apologize. The WIC agencies and CIS. This helps streamline the benefit determination process with ADRCs specifically, where there's an authorization from a patient for the ADRC to gather clinical information to then determine what benefits, state benefits, the individual might be eligible for. Historically, that's and today still, that's a manual, paper chase, faxing, etc. We are looking to provide efficiencies to that whole process, benefiting the patient. Coordination of care, specific to WIC agencies, removing some of the administrative burden that exists and delays in accessing the information, allowing those WIC agencies to access the BMIs, the other information related to those services that they need, and putting that at their digital fingertips. And then finally, CIS. So we are working with Brown County population, and I'm sorry, Matt, I'm butchering the name, but it's a collaboration of providers and payers, community-based organizations that we are working with, and calling this out specifically. It's been we are looking to explicitly state these organizations, as there may have been underlying and agreeable state and federal law that these organizations could access WISHIN, and in some cases that has been permitted. Now we are just saying it explicitly, all using in accordance with HIPAA, privacy and security, and again, state and federal law. All of these organizations that have access to the network can be accessed through our website, wishin.org/participant map. It's under the subheading or menu of participants. Okay, so addition of 3.11. So under section 3 of the data sharing participation agreement is data that is permitted to be exchanged through the network. And we are adding through this change SUH and HRSN data. Through this use case, WISHIN would look to receive, and we already are receiving, and this was motivation to make it explicit how we would receive this data and then be able to allow our participants to access and use this data. So WISHIN would receive, store, redisclose SUH data, HRSN data that exists discreetly through a new feed, maybe through a Find Help or other type of vendor, or data that exists within continuity of care documents or other discrete data interfaces. that we can pull together and then partner with community information exchanges or CISs or other those vendors and have a reciprocity where data can be exchanged and inform closed loop referrals, and are those patients, individuals getting the services they need. A couple definitions were changed under section 27 of the PA, the participant advisory board. As we were calling on that board and convening them to come together, there had been some substantial changes to the membership. Maybe an individual has left, they didn't have the bandwidth to continue their membership. So we're adding some language that will go through a governance committee that meets as necessary, but at least once a year to review and adopt any changes through the WISHIN board of directors. And again, the PAB only meets as necessary to review any potential modifications or substantial changes to the PA. Under SDOH, to align with the health-related social needs, SDOH permitted data source. It was important and prudent for us to add a definition of SDOH data to the participation agreement. And we only have a few more left. I do see a few things in chat. So again, please use that if there are any questions. We will come back if necessary. So moving on to the attachments to the participation agreement. Schedule 1 to attachment 1. So attachment 1 is the section of the PA where organizations elect specific services, whether it's Pulse, the patient activity report, quality reporting, or DAV certified data. And then a supporting schedule to that attachment 1 identifies and is a bit more explicit about what those services are. And when the board adopted and approved health plans to be broader participants of the network back in 2017, effective 2018, we added this section 3.3, which define how a healthcare payer would have access to the services, and that as part of that, given our network is a reciprocal, maybe a co-op, someone could liken it to, that organizations must provide data as they're receiving data. There are some caveats and variations to that, but for health plans specifically, or healthcare payers generally, these organizations are bound to a payer access policy, and within that policy, the payers are required to send some data assets, which will expand as our network technology infrastructure projects close. So back to this use case, since the health plans have had access to WISHIN Pulse, providers have stated that there's some language that needs to be added so that health plans are committed to communicating with healthcare providers related to the coordination and management of members. Just to be clear, WISHIN is not implementing a checks and balances. We are not implementing a process, but we are expressing here with the language that we're adding, where healthcare payers must coordinate with the providers where their members are seeking care. And then additionally, to clear up any gray area, healthcare providers may elect to opt out of data sharing of specific health data for any of the permitted purposes under attachment 4, use case 8, which we'll get to soon. So that's what we've done here. Again, WISHIN is not putting in a process to audit you access data as a health plan for this individual at provider A. Did you make a call? We are not going to be doing that. But this is on essentially an honor system that payers, you need, if you're accessing data within WISHIN, you need to be coordinating with the providers. I think that makes sense. I think these things are happening today. So this is not a broad slash against any payers. We're just hearing more coordination needs to happen. So that's what's going on there. Related to use case 7, when these permitted purposes under use case 8 were adopted, use case 7 was changed slightly, and given the growth of the network and to better harmonize use case 7, which is, as it says, sending transactions to payer organizations for their members. That's happening in a very automated way where from the payers, they send us a roster. We only lift the gate for the permitted purposes for those payers and specific roles to access data. We wanted to be much more explicit within 7 what that meant. And as it states, harmonize 7 and 8 as we've been conducting business under the assumption that's been happening. So we've been asked to clean up this data, which we have done here. Under 8, the permitted purposes, as I shared, approved in 2017 and then effective February of 18. Health care payers had access to WISHIN Pulse for claims adjudication, prior authorization, collection of quality data, and care management. We are adding a 5th permitted purpose and use of the data after many years. It didn't take long. Maybe it was 2019, 2020, where payers started asking, hey, can we use this data for risk management, risk adjustment purposes, utilization management, etc. These payers were not able to draw a straight line. So this is allowing, as they're bringing in data and merging it as permitted within their care management systems, their HEDIS systems, whatever other systems, in accordance with state and federal law and in accordance with the PA. Now we're adding risk adjustment to help with the value-based arrangements that might exist, the shared risk, the shared savings, how WISHIN makes sure that there's specific users in specific roles is Laura and her team through the system have created claims adjudication roles, prior authorization roles, and will or has created a risk management role. And those users cannot cross various roles. They have access to the network for those specific roles. They can access those data. We audit, and as part of the administrative functions that you and your organizations have, any questions you have about administrative reports or audit reports, please let us know. and we can retrain. But that is where an organization, specifically talking about provider organizations, can look at who's accessing that data. But then on the payer side, your obligation also to audit and make sure that your designated folks using WISHIN Pulse for these purposes are being audited as part of your weekly, monthly, quarterly, however you audit your systems. Okay, then the last modification that we have is the addition of use case number 10. This has been as long as I've been at WISHIN, 10 plus years now, is organizations looking to use WISHIN in a population health manner or cohort specific data assets. And until the PAB had reviewed this new use case, and now the board has adopted this use case, can we then offer next year some data assets, some visualizations, in the future, dashboards and enhanced analytics. We're going to start looking at offering data sets for those organizations where you have a treatment or otherwise permitted purpose with an individual or a cohort. So say you wanted to manage your gaps in care for a specific cohort, maybe diabetics, maybe high blood pressure, hypertension, maybe those two are the same. I apologize, I'm not a clinician. But now WISHIN will be enabled to use a data asset. We'll call it a data warehouse, where it's, instead of organizations trying to put this together, and we understand that the larger EMRs are offering the service, we can be complementary to those existing EMR services, or we can also provide unique services that may not exist, or for quality purposes, you're looking for different data assets. So we have a couple of examples here on the screen for you. Won't go through all of them. But also, it will be a different revenue opportunity for WISHIN. And as we look for the viability of the network and sustainability to continue to provide cost-effective services, this will help advance our goal to provide data for your patients, and leans into providing all of these use cases, providing better services that equate to a healthier Wisconsin. So with that, you can unmute yourself if you have questions. I'm not sure who's managing the chat, Lisa or Greg or somebody on the team that can help. Maybe Tom. I don't know if Tom's on.
Yeah, Steve, I can kind of run down some questions. The first comes from Jill asking for an example of a CIS participant.
Okay, so Matt, you want to take this?
Yeah, Jill. So the only example today is the one that Steve mentioned, and it's a population health collaborative in Northeast Wisconsin that brings together hospitals and health systems, managed care organizations, and community-based organizations in communities in Brown and Kewaunee County. And the organizations who are WISHIN participants who are participating in that Pop Health Collaborative have asked WISHIN to serve as a vehicle for exchanging information between those participating organizations. And so what the change in the PA language allows us to do is to really facilitate that data exchange in that community. We're only exchanging information from those organizations who are active participants in that CIS, and would sort of look for active participation of other organizations before we would start exchanging data through any other CIS. But we found a need to add this language to the PA to sort of cover that work and any potential future work. So Steve, I don't know if you have anything to add to that, but
no, one of the participants on today's meeting, Christian Rovers, thanks to him for all the work to help develop that in Brown County. And we look to Brown County to really set the stage and plow the ground for what's possible. And we're already seeing fruits of all of that organization's labor. I'm not sure if Chris Elfner is on this call either, but he has led that in partnership with a few other instrumental folks. And what the goal here, as I said, is to lay that foundation of what we can bring into different geographic regions or possibly across the state of Wisconsin to help manage the care of these individuals cross systems. So it's supporting exactly why we exist, is to facilitate that exchange regardless of the size of the organization, through these permitted uses and permitted purposes, allow that data to move seamlessly. Jill, did that answer your question?
Yes, I guess just one add on to that, Steve, is when that expands to other CIS, will the providers be advised of that, the additional?
Yeah, it's I would say, and Matt, please share your thoughts, but it is vital that the providers are part of that conversation. One, you have to in some aspects continue that participation and partnership with the community-based organizations. Some organizations that we WISHIN don't participate with. So what we're seeing in Brown County is that's it's an independent collaboration of folks coming together. We are just help facilitating some of that data to move. So it's not an additional burden to providers or payers. Matt, anything else to add there?
nope.
We will bring you along. Short answer, yes.
Okay.
Next question.
And I guess, sorry, Greg, I would say to any provider or payer on this call that's interested in spinning something up in their service areas, to keep us in the loop, because we can again help move that data and convene some of those relationships.
Great. Next question I see is from Sarah asking, how do providers see data shared by payers? That sharing, she's asked providers, and they're unsure they're able to see payer data.
So Sarah, being from Molina, I guess you're asking this question from the position of a payer, like what and how they can see it. It is today it's very limited data and that payers are sending into WISHIN to be accessed by providers. We started with field medication lists, and we had to halt that exchange from payers for some time now, and will re-engage. What primarily exists are the HMO SSI population care plans from health plans, and that was a state funded project and requirement for the SSI population to send care plans, and that's helping coordinate care for those individuals. That's and I look at the team just to validate what I'm saying. I don't think the medication reconciliation, that is ceased. What also exists on that list, and this is from memory, so I apologize, is like health related, health risk assessments that payers would would conduct and then be made available through WISHIN. These are all that is a future functionality. We need to get the pharmacy fill data from providers to help with med compliance and reconciliation. So that's something that is still on the list. Sarah, does that answer your question, or you have any follow-ups to that?
I do, Steve. Thank you. So specifically, I was wondering about that care plan data. I have recommended to providers that they could tell whether or not someone was actively engaged in care management by looking for that care plan. But I have actually been on calls with providers who are trying within Epic to utilize Care Anywhere to see, and they tell me that no Molina data pulls in. And so they're not sure how to even find our care plans.
I have an idea. And it already exists, but what the limiter might be, Sarah, and exists today is what we're gathering from payers is limited to the SSI population. Health plans, and that's a result of the Medicaid contract, if I remember correctly. I'm not sure if it's tied to anything else specifically as far as a requirement, but as part of section 3.3 and the payer access policy that I mentioned previously, care plans, regardless of the member and the line of business they're attributed with, would be a requirement to send to WISHIN. So it would be the full population as those care plans are available that they're sent to WISHIN, and it's essentially using the same infrastructure, the same exchange requirements for the state required care plans.
So I guess my question is inclusive of current state. Specifically, I was on a call, I believe it was with care managers at MHAC in Milwaukee County. It was an SSI member. And I could see in Wish Impulse that there was care plan data, but they were unable to see it. So it's wonderful, and I would love to be able to share my care plans, but I'm struggling to understand and help providers know where to look within their systems to be able to see that.
Steve, do you mind if I
Yeah, please, Laura. Thank you.
Sarah, I have a quick question. One of the things you mentioned, and I don't know if it was a slip or if they're looking somewhere else. When you said they were looking in Care Everywhere, were they looking inside their Epic system or were they looking in
Yes.
Wish and Pulse?
They were looking in Epic. I have not met a single provider that's accessing Wish and Pulse personally.
Okay, so there are a lot of MHEC users who do have access to Wish and Pulse, and the care plans are not in Care Everywhere, they are in Wish and Pulse. So there's a couple different things that we can talk about with MHEC to get them access to that information. Number one is set them up in Wish and Pulse if they're not already there, or remind them that that's where the care plans are. The other thing is MHEC has sends data to WISHIN through Aurora.
Yep.
And Aurora has not implemented query and retrieve with us yet. I know that they have that on their list, but they have not come around to it. And that is why they don't see it in Care Everywhere, because they would have to do a query and retrieve to us to pull that data into their Epic system. So if you have people you're talking to at MHAC, you can feel free to refer them over to me. I can get them in Wish and Pulse if they're not already there, or get them set up again, remind them how to use it, or we can talk to Aurora again about when their plans are to implement query and retrieve, because they have it on their list. They just haven't um, implemented it yet because it's not high on their priorities of projects, because everybody has millions of IT projects. But if um, we can get some of the users to say they need to get this on their list of projects, that may get their IT to up that in the priority list.
Thank you, Laura. Are there a number of providers that are using that query?
Well, it depends. Some of them use it an automated query and retrieve so that they don't have to leave their actual system. They're just staying in their own system. Um, it's kind of a mixed bag right now. A lot of the Epic organizations like to just use the query and retrieve, so they're staying in their Epic system.
Okay. Thank you, Laura.
I appreciate you bringing that up, Sarah. Sounds like a specific education opportunity for us, and allows then through that automation or access through Wish and Pulse for payers to meet the requirements of 3.3 related to the continuity of care conversation. So thank you for that.
Steve, the next question we have in the chat's from Daryl, asking if we can expand on what the payer communication might look like under 3.3.
And I think I touched on it already, so I'll go over it. And Daryl, if there are any questions or from any other health plans. So as many of you know, there has been this WISHIN 2.0 project that we have been working on. And what we have done as a dependency for the requirements of the payer access policy is put a hold on that data onboarding because there would be efforts to build things within an environment that is going away. 2.0, we are on track for late Q1 of 26. We are making advancements to meet that new goal line. And then as that comes to fruition, that's live, that's stable, we will go back to our payer participants and then reassess the capabilities and feasibilities to send the required data elements that the payer access policy has identified. And again, it's medication fill history, care plans, health risk assessments, in-home reports. There's one or two other data elements that I can't remember right now, but so probably mid to late Q2, we will have a specific engagement and outreach with payers, how to be compliant with 3.3. Daryl, any other questions or follow-ups or any other health plans that might have inquired the same?
Oh, sorry, I was double muted. So I think that relates to what additional data payers might be desired, required to send in. As part of 3.3, there was a communication part relating to, when payers are accessing pulse information for various purposes, that they would communicate. Are you viewing that as tying together, or is that separate?
Well, it's a requirement of all health plans that are accessing WISHIN for any of the services to have that coordination. Again, we are not going to police or have some auditing and checks and balances of how that's happening, but it's a reference back to this reciprocal agreement that everybody's working from. that those health plans need to coordinate, and I'm just saying this generally, maybe coordinate better with health providers to help manage the care and continuity for those patients. What I heard from Sarah is leveraging Pulse and reviewing those care plans, going back to an education and to providers that, hey, these exist for a population and might address the requirement for that care management coordination conversations that need to happen.
Appreciated. I'm gonna take different use case that pairs might often have. Even if getting the DAB feeds, at times not every bit of information is flowing in a way to make use of. So we might have somebody logging into Pulse to check if a particular information relating to a quality gap is present, and if it's there, then we might order a chart in order to have the information from the system. Would you assume that ordering a chart sort of, if we're requesting the chart from the provider, that basically is communication, right? I mean,
No, the specific language, and I'll go back up to that.
or maybe I'm delving into a use case that's non-applicable. I'm not sure.
And that's fine. That's where we're having this.
Location care. Okay.
So it's not. This is specifically how this was how this came about is for the care management use case, not the quality, not the prior auth, because through the prior auth there's going to be the communication. What providers had expressed is that there might have been some opportunities to better coordinate with some of the patients members under the heading of care management permitted use
Okay.
under use case 8, and that they're asking for better coordination under the care management use case.
Related to that. Okay.
Yeah,
Appreciate it.
because it's essentially payer consuming that data and maybe not looping back with the provider. That's really the genesis of where this language came out of.
Appreciate the clarification. Thanks, Steve.
Yes, sir. Thanks for questions. Is there? I'm sorry, I tried to go through the slide deck and I will reshare here in just a second, but any other questions?
Steve, two more from the chat.
Please.
From Jill asking if will risk adjustment influence patient premium or provider contracting costs?
Well, we're not a part and party to the costs or negotiations. We are here to be a convener of the data and be able to look at how we can empower the providers and payers to collaborate. I would say that for those specific arrangements, risk arrangements, MSSP kind of arrangements that exist. But yeah, we are not going to get in the middle of negotiations or contracts or pricing or anything related to the value-based programming or MSSPs that folks are working with. We do see an opportunity to help benefit providers related to RAC and HCC coding, where that can help your CMS reimbursements or how that process plays out. Through this, we can now maybe help facilitate some of that coordination, but not stand in the middle or stand in the way of contracting and pricing.
And then one last question in the chat around population health analytics, and wondering if that data will be supplied on the patient identifiable level or on the kind of more aggregate, like by zip code, et cetera.
Matt, you want to address this one?
Yeah, Jill, it could be either. But again, participants will only have access to that data that they're already eligible to have access to. So, patients that they have a care and treatment relationship with, or on the health plan side, members that are already part of a member roster that's being sent to WISHIN. But the idea is that WISHIN can either provide tools, which may contain, higher level, zip code level, or geographic data, or, different population aggregations, or WISHIN could also provide data sets on specific populations so that, again, organizations didn't have to go into Pulse and pull data one patient at a time, but we could provide bulk data that can be used for different pop health applications.
This is Daryl. I did have a follow-up to that. Any thoughts on doing de-identified data sets that might be useful for, some analysis?
Yes, so we have given some thought to doing that. I think I don't think that this use case completely covers that though, Daryl. So I think we need to have some conversations probably with the participant advisory board, as well as some of our other committees before we'd provide broader de-identified data sets.
And just to be clear, related to de-identified data sets, that this does not include research purposes. That's still not an approved purpose at this time until our participant base identifies it as a priority and the PAB and board do adopt those changes. But just want to be clear that this is not permitting WISHIN to use the data for research purposes today. We again, as I shared earlier, this has been a use case that we have been asked about for a long time, and now we are enabling that. Thanks to the PAB's work, thanks to the board of directors for aligning with the vision of WISHIN on how to bring that value to our participants. And we understand that WISHIN, Pulse, and PAR provide great services, as does DAV, but I mean, we think this is going to be really a game changer for managing cohorts, identifying gaps in care, et cetera. Anything else? We have 6 minutes.
Steve,
Jill, is
could
that
you?
you? Hi, Jill.
Yes. Could you talk a little bit about opting out and how a provider would do that if they chose to?
Sure. There you can send an email to wishin@wishin.org. There's a form that would need to be completed as essentially an amendment to the participation agreement that is executed, and then those desires would be represented in technical controls for organizations to not have that data available. And we can go through that that whole process, but it's a one-page form, and we align with essentially it's for the provider organizations to make an informed decision and figure out how they want their data to be accessed. So we can throw that email in the chat, and that will be available to everybody who requires a follow-on conversation. Any other questions? Well, if not hearing any, not seeing any more in the chat, thank you for taking the time here. We do have a second session coming up in, when is it, Lisa? I'm sorry, it's sometime in early December, I believe. So we will talk to you all soon, or if you have any questions, please reach out to us and we will address those. Thank you so much for joining.
Thank you.
Take care.
Thank you.